Okay. All right, just waiting a second. Okay. Hello and welcome everyone to this evening's webinar on breast cancer awareness, leveling the playing field. Okay, we're just waiting a couple moments before we get started. Okay. Welcome again to this evening's webinar. My name is Tina Robinson, and I am a member of the Harbor Area chapter of the Links Incorporated, and also chair of the Health and Human Services facet. In my professional capacity, I am the Housing Accounting Director at Retirement Housing Foundation, which provides affordable housing to seniors, low-income families, and people with disabilities, serving throughout the states, the Virgin Islands, and Puerto Rico. So at this time, let's go over a few housekeeping items. Here we are. Please be aware that this session will be recorded and will be available on the Harbor Area chapter of the Links Incorporated website. All participants are on mute, and videos will not be shown except the panelists, the moderator, and host. For questions of your presenters, please type your question into the Q&A function. Questions will be provided to the presenters throughout the session to answer. A survey link will also be provided at the end of the session. Please provide your feedback. And please use the hashtags, hashtag HAClinks, hashtag linksheal, and hashtag HAC leveling the playing field on social media to share your thoughts and takeaways and comments. We have a number of dynamic speakers this evening, so without further ado, I'd like to introduce our moderator for the evening, Marian White. Marian White currently serves as Clinical Nursing Director with Los Angeles Department of Health Services, Ambulatory Care Network, where she oversees nursing services at Hubert H. Humphrey Comprehensive Health Center, Bell Health Center, Long Beach Comprehensive Health Center, Wilmington Health Center, Bellflower Health Center, and Torrance Health Center. Marian is a member of Sigma Theta Tau International Nursing Honor Society, the Council of Black Nurses Los Angeles chapter, Dillard University Professional Nurses Organization, the American Academy of Ambulatory Care Nurses, Chi Eta Phi Sorority Incorporated, Delta Sigma Theta Sorority Incorporated, Rolling Hills Rolling Hills Palos Verdes Alumni Chapter, and a 20-year member of the Harbor Area chapter of the Links Incorporated. Marian.
Thank you, Tina, for that introduction. The objectives for tonight's webinar: at the end of this webinar, participants will be familiar with the HEAL program and the Links Incorporated partnership with the American Cancer Society. They'll be able to identify the prevalence of breast cancer and the importance of advocating for your health, state the importance of addressing mental health in the context of a cancer diagnosis and treatment, learn ways that caregivers can assist family members who are battling cancer. At this time, I'd like to introduce Dr. Valerie Green Amos. Dr. Valerie Green Amos currently serves as physician director, lead physician for Optum Health, formerly known as Healthcare Partners for the Long Beach community, with clinical oversight of practices in Compton, Long Beach, and Downey, California. Dr. Green Amos has over 18 years of managed care and primary care expertise, including physician management, chronic disease management, risk adjustment, culturally competent care, clinic leadership, and patient satisfaction. Dr. Green Amos is board certified in family medicine and is a bilingual Spanish-speaking physician. She and her husband have been residents of Long Beach since 2007. Dr. Green Amos is currently the president of the Links Incorporated Harbor Area Chapter and a member of numerous organizations, including the American Academy of Family Physicians, California Academy of Family Physicians, the National Medical Association, Delta Sigma Theta Sorority Incorporated Orange County Alumni Chapter, the National Association of Spelman College Los Angeles Chapter. She is a member of the Antioch Church of Long Beach. Please welcome Dr. Valerie Green Amos.
Thank you so much, Marian, for that beautiful introduction. It is my honor and privilege to serve as the president of the Harbor Area Chapter of the Links Incorporated. I think it's so important that we focus on the diseases, the challenges, and opportunities that really impact our community. The purpose of the Links Incorporated is to honor women, families, and communities through friendship and service. Tonight, we're going to focus on breast cancer. The Links Incorporated has a long history of providing service to communities, as I've just discussed. But it's been even more important that we address something that's so critical. It's so critical today, which is health inequity. As many of us are very familiar, diseases that affect the community affect us much more challenging. We are the ones who suffer the most, and we are the ones who don't get the access to care that we deserve. Part of the problem we know is cultural, is systemic, and it's really based on bias. But part of what we intend to do is not focus on the problem, but focus on the solution. Through the American Cancer Society, the Links Incorporated have set aside significant financial supports to encourage information that's vital to affect our communities. Our first approach at this, through the Harbor Area Chapter's Health and Human Services facet, is to address breast cancer and breast cancer awareness in African American women. We know that this is another tragedy of what has happened to women of color in this society. Black women, though, are not diagnosed more often than white women, but we have the worst outcomes. We suffer from greater disease burden, we suffer from higher rates of death, and we suffer from a lack of information that really reflects our cultural knowledge, our background, and our best interests. So tonight, we as the women of Harbor Area Chapter and other great friends are here to advocate, to encourage, and to educate women, specifically around the value of screening, the importance of knowing what breast cancer is about, and for spreading awareness. Tonight really is around spreading awareness. If anything can be heard, said, or done through the knowledge that anyone on this webinar or in the future hears tonight to encourage change in our community, then we have done our job. What we know is that this is a national and international problem, but in particular in Los Angeles County, we know that the community that we serve, and we serve specifically South Los Angeles County, that the incidence of breast cancer death is much higher than the incidence of breast cancer death throughout the rest of the county of Los Angeles. And you can almost guess what the residents of South Los Angeles look like. We are the reflection of these individuals who are indeed dying at rates that are much, much higher than the rates of women in other communities. And again, that was a call to action for the Harbor Area chapter. So we decided that if nothing else, we would develop the tools and resources to go out in our community and spread awareness about the incredible value that breast cancer screening has, and the importance of knowing what screening opportunities are available, what treatment opportunities are available, and what resources we have to help our entire community. So it's a wonderful, wonderful opportunity for us to be together and talk about such an incredibly important topic, which is breast cancer awareness. Now, certainly my role as the president of this dynamic chapter is to ensure that we are leading by example. But as a physician who primarily does geriatrics, as a family physician who's focused on geriatrics the last 20 years of my career, I can only tell you how critical early screening and detection are to improve the lives of our community. So it is an absolute pleasure that through the American Cancer Society grant, in collaboration with the Links Incorporated Harbor Area chapter, that we bring this information in this particular webinar to you this evening. And we look forward to a dynamic conversation. Thank you for joining us.
Thank you, Dr. Valerie Green-Amos, for your physician perspective. At this time, I'd like to introduce Dr. Tasha Dixon. Dr. Tasha Dixon currently serves as the family medicine lead attending at the Martin Luther King Jr. Outpatient Center. Dr. Dixon currently serves on various local and countywide committees to support and ensure that healthcare is delivered in a safe, just, and culturally appropriate manner while working towards addressing medical mistrust. Throughout the pandemic, Dr. Dixon has worked on the front lines helping to treat patients so that they are aware of the COVID-19 virus, and now she's advocating for COVID-19 vaccines. Honored by KMBC LA for Black History Month 2021 for her contributions to the community, Dr. Dixon is passionate about caring for the ill and immensely dedicated to preventative care and improving healthcare outcomes for people of color. Dr. Dixon has contributed to various print, radio, and television outlets, and most notably featured on the 11th Hour with Brian Williams, Good Morning America, and most recently, the California Healthcare Foundation. Dr. Dixon is a member of several professional and community-based organizations, including the National Medical Association, the American Academy of Family Physicians, and Alpha Kappa Alpha Sorority Incorporated. Please welcome Dr. Dixon.
Hello, good afternoon, good evening, actually. Thank you all for having me. Thank you to the Harbor Area chapter of Links. And I am so happy to be here talking about something that I'm so passionate about, as well as Dr. Green-Amos. So today we're just gonna jump right into it. We're gonna talk about breast cancer and the patient perspective and really advocating for our health and for your loved ones. I thought it'd be important to kind of understand the foundation of this serious disease. So what is breast cancer? First, cancer is a disease in which some of the body's cells choose to grow uncontrollably, and they sometimes will spread to other parts of your body. In this case, of course, your breast. It's a cancer that starts in your breast, and it can affect one or both breasts. and it actually can affect both men and women. There's a variety of types, depending on which type of cell mutates. So you can have adenocarcinoma, or you could have something called Paget's disease of breast, or the others that are listed. Next slide, please. Breast cancer is the second leading cause of death from cancer in American women. And some reports are starting to say that it is now taken over as the world's most commonly diagnosed cancer. It affects more than 2 million women globally each year. Every 4 minutes, someone's diagnosed with breast cancer. So in the next 4 minutes that I'm talking, think about that someone's loved one is being diagnosed. Among younger women, Black women have the highest rates of breast cancer in comparison to white women. And just to drive home, really, that screening and early detection, like Dr. Green-Amos was saying, is so key. You'll hear me say that a lot. That's a take-home message. I definitely want you, if you don't remember anything else from this conversation, that screening and that early detection is definitely key to survival for us. Next slide, please. Taking a look at some of the numbers, you see that the rates have steadily over years have continued to increase. Next slide. By race, you also see that it affects us almost, so we're second in line for how many women it affects per 100,000 women. So when you compare us to our Asian Pacific Islander counterparts, our Hispanic and Latinx counterparts, we're second highest. Next slide, please. Taking a look globally, so you remember 2 million people, but when you look at the type of cancers that affect us as women, when you look at that color, you resoundingly see pink as the top cancer that affects most countries in the world. Next slide, please. Taking a look at just LA, and this is information and data from Susan G. Komen, when you look at the age-adjusted rate, that's a way for you to kind of take age out of the picture and compare. When you separate by race, you notice that African-American women have the highest, or one of the highest numbers of deaths and the numbers of late stage rates. So that's women or men that are being diagnosed in later stages, where the options are not as efficient and not as good. Next slide, please. So in LA County, we divide up the areas by something called SPA, or service planning area. And that's depending on what area you're living in. So the area that I happen to work in, and the area that Dr. Green-Amos also kind of works in, is Compton. And when you see Compton, we are in SPA 6. SPA 6 is actually larger than 9 states. And actually, Los Angeles County as a whole is the 9th in the country. So the largest county in comparison to quite a few states. And when you look at SPA 6, we are one of the largest, even larger than the Dakotas. You look at the rates. So the gray is those SPAs fare better. The black is those SPAs fare worse. So when you look at each of these cancer rates, the one we're pointing out tonight is breast cancer. You see that we tend to fare much worse than our counterparts that may live in the beach cities, that may live in Santa Monica, that may live in Hermosa Beach, or in some of the more affluent areas of Los Angeles County. Next slide, please. What are some of the causes of breast cancer? So some of the things that it's affiliated with are obesity, family history of breast implants, hormonal therapy, including birth control, your lifestyle, the age that you started your first period, the age at first childbirth, or if you breastfed, lack of physical activity and exercise, and alcohol consumption. Think about how many of those we can control and how many of those we can't. So we can work on obesity and having a healthy lifestyle. We can work on the exercise. We can work on the alcohol. We can work on the hormonal therapy. In some instances, we can't control the hereditary, but so many of these things we can in choosing healthier lifestyles. Next slide, please. And assessing your risk, because so many of us ask, well, am I at a higher risk? Some of the things that we as physicians will use is something called the Gale model, which can be used to estimate your breast cancer in the next 5 years to lifetime. It factors in like the age at first period or menarche. It also factors in the age at which you had your first child, the number of breast biopsies you may have needed to have, your race and ethnicity. And at a certain percentage, 1.67, you're considered as high risk. And if you're in that range higher, I definitely recommend talking with your primary care provider or doctor. Next slide, please. In terms of the methods of how you can screen for breast cancer, it really should be customized based on the needs of the patient and their history. The most common way to screen is mammography. And there are several ways that can now be done, whether it be film mammography, digital mammography, or tomosynthesis. MRIs are used in some instances, and they can also be used to screen for women who may have a higher risk. Some other things that are being studied, are breast exam, thermography, and tissue sampling. Next slide, please. Several organizations have weighed into what recommendations should be. There's a lot on this slide. I recommend taking a picture of it if you want to have it later on. But the summary of this is that between 40 and 50, the recommendations vary, and it's definitely recommended that you talk with your primary care provider. But by age 50, all organizations recommend routine screening. So the average woman typically at 40 should start to think about that. So I'm turning 40 this year. I will be getting my mammogram this year, despite being told that it's painful and those things. I'm getting it done because early detection and screening is key. Next slide. So to do the self-breast exam or not, I recommend it. There are some recommendations against, but what I'll say, I think that it's helpful for every one of us to know our bodies and every one of us to know when something's different. That's sometimes the most important thing and key for you going to start that conversation with your doctor. So say you haven't gotten your annual mammogram and you're doing your breast self-examination and you notice something feels different. That's another time to go and talk with your doctor about breast screening. So how do you do this? So you're going to pick the same time each month. Sometimes with your period, it can vary when you may have some lumps and bumps in your breast. What we're looking for is something different. You'll look at your breast, you want to have your hands down, and then you lift also. You're going to use the pads. You're going to look and feel for any hard knots or any other changes, any signs of swelling or dimpling. If you're having any breast discharge, any of those things are definitely concerns that we recommend you go and talk with your primary care provider about. Next slide. So some of the reasons that I've heard that we don't get mammograms. So two of the most common are right on here. It's painful, it's embarrassing, I'm lazy, expensive, no insurance. Something after this one is now the pandemic. And so we are starting to see a lot of women who, because of the pandemic, didn't come in or they were afraid. This is the opportunity for everyone on this call to check in with your loved ones that are 40 and older. Have you had your mammogram? And open up that conversation, advocating for every one of your loved ones that should be getting their mammogram. So that the doctor didn't tell me it was needed. We know from today, starting at 40, we should have that conversation. Definitely by 50, we should have our first mammogram. I don't have a reason, that's definitely a what are you waiting on? Go and get your mammogram. I didn't know it was needed. We're telling you now, call your sisters, call your sorority sisters, call your fellow Link chapters members, and have this conversation. It will save someone's life. Next slide, please. So if you have questions or you're concerned that you may have breast cancer, definitely, please make an appointment to talk with your healthcare team to discuss this. Urgent care and emergency departments are definitely available, but less ideal given the pandemic, but they are available when necessary. So if you have nowhere else to go to one of them. They will definitely be able to help. I know my urgent care as well, the emergency room on campus, we will take you in and start that process. Next slide. Signs and symptoms. So we just talked about that exam. Just reminders that lumps or swelling, any changes to your skin or changes to the contour shape of your breast, any nipple changes or any crusting or anything out of the ordinary. So let's say you saw nothing. what are signs and symptoms that you may have breast cancer? So you may be feeling sick, someone may be having headaches, have a dry cough or breathlessness, maybe start losing their balance or unexpected weight loss. These aren't things that that always mean cancer, but just things to watch out for as well. And once again, early detection is key. Next slide. So advocating, this has been the thing, and I think it's going to be the message going through this evening. Your overall health matters. So those routine and annual health exams with your primary care provider are definitely key. Access your healthcare system. You have the right to healthcare, especially when you've got insurance. I know many of us, we have insurance and we kind of take it for granted. Use it. Go and see your doctor. Go and just check everything out. Get your blood pressure checked, get your labs checked, just to make sure that you've got that clean bill of health. Those routine preventative care things include that blood pressure, that cervical cancer screening, that colon cancer screening, which has now been moved to 45 and up. Continue that heart healthy exercise. Obesity and lack of exercise and physical activity are associated with increased risk of breast cancer. That nutrition matters. Education is so important. Knowing those reputable sites where you can learn more about your health and medical conditions. And lastly, don't just advocate for yourself, advocate for others, advocate for your community, for improved services, for more research around cure and screening modalities for breast cancer. Next slide. My references are here, and these I definitely recommend as places to go for reputable information and data and statistics around breast cancer. And I think that that is it for me. Definitely happy to be here, and I'll pass it on.
Thank you, Dr. Dixon, for helping us to understand the prevalence of breast cancer. Next, I'd like to introduce Dr. Deanna Harris McCoy. Dr. Deanna Harris McCoy is a licensed marriage and family therapist, an associate professor, and specialization in marriage and family therapy program director at Northern Illinois University. She has presented research at various local, national, and international conferences concerning Black mental health, adolescence, and social justice within the field of marriage and family therapy. She is extremely active in her professional associations and served as the co-chair of the 2017 American Family Therapy Academy Conference, and has served on the National Election Council of the American Association for Marriage and Family Therapy. Dr. Harris McCoy is a former AAMFT Minority Fellow and is currently serving as the Executive Program Consultant. She has received multiple awards for her community service, social justice work, and leadership. Dr. Harris McCoy was diagnosed with breast cancer in 2020 and is currently in treatment. Please welcome Dr. Harris McCoy.
Thank you so much. And I really want to thank the Harbor Area, California chapter of the Links Incorporated for inviting me to share my story tonight. And I just wanted to let everyone know that the Links Incorporated is such a wonderful organization. I myself am currently a part of the Hoffman Estates, Illinois chapter. So I'll give you all a brief story because it's long and it's still going on, but I'll give you the very short version of it. So somewhere around March or April of 2020, while we were still in the throes of the pandemic, I felt a lump on my left breast. And I'm like, it doesn't feel right. It doesn't feel normal. This is not normal for me. But I didn't really think too much of it. So then later on around June, I felt it again. And I'm like, this feels like it's getting bigger. And one of my really good friends urged me to go and talk to my primary care physician because she had a friend that was also experiencing breast cancer. And so I made an appointment with my primary care physician, and she did a screening and then made a recommendation for me to go and actually get a mammogram. And so I was too young, still too young, because I was 35 when when I actually felt it and when I was diagnosed. I was too young to actually get a mammogram. So this is why I encourage everyone to do self exams and to know your body, or have somebody know your body so you can tell when something is off. And so I remember when I went to go get my mammogram, and I sat it in the dressing room, and the woman gave me the clothes to change into. I had this like eerie feeling that something just wasn't right. Like I just had this feeling that something wasn't right. So we did the mammogram. I think they also did like an ultrasound there too. I think that I then had to come back for them to actually get a biopsy of the lump. And again, I remember all of this like it was just yesterday. So on August the 1st, and that time I was living in Texas, I was out doing community service with the Lone Star Texas chapter of the Links Incorporated. We were handing out backpacks for a backpack drive. And I got the call from my primary care physician saying that they found something and I had breast cancer. And so when I got off the phone, I immediately called my husband. I think I might have shed a tear or two. He was on his way home. But then I went back, I told all the other members of the chapter about it. And they were very loving and supportive. And in true Deanna fashion, I still continued doing my volunteer work for that day until it was over, just in true Deanna fashion. And so when I went home, I just went and just like cried to my husband because I'm like, oh my gracious, like, oh my gracious, this is it. It just seemed like almost like my world was ending there, but I still wanted to have a lot of hope. And also, true Deanna fashion, I started a new job a month before I was diagnosed. Then I actually moved almost like 9 days, 8 days after I was diagnosed. So then I had to, in this new state, I had to find a new primary care physician who then set me up with oncology. And I talked to a breast surgeon. And so I went through some of the options that we had. And she was telling me that because I was also HER2 positive, that I would have to do chemotherapy just regardless. And I was trying not to do it. I'm like, okay, if I have the surgery, even if I have a mastectomy or a lumpectomy, can I just not do the chemo? Because I did not want to do it because she talked about all the potential side effects. I was okay with potentially losing my hair, as you can see from the picture, but would really stopped me almost, and I was fighting it, was the potential for infertility, because my husband and I, we don't have children yet. So I was crying in my breast surgeon's office. I'm like, I don't want to do the chemo if it's going to mean that I may not be able to have children afterwards. And so she said, we'll set you up with the fertility department before you even start the chemo. So before I even started this whole chemotherapy process, I had to take the fertility drugs, give myself the shots. And so we could at least have an option just in case there was infertility after the chemotherapy. So my husband and I have embryos frozen right now, just in case anything happens. And started chemo November of 2020. And I'm going to say this a lot because it's always in true Deanna fashion. The day after I started chemo, we closed on our house. So it's always a lot that's happening in my life, always a lot. And so when I started chemotherapy, I decided that I was going to create like a whole separate Facebook group around it. One, because I know that I would need a lot of support. So I really let my Superwoman cape go like a long time ago. I think it's maybe like this big now. And I knew that I could not do this by myself, emotionally, physically, just everything. I just couldn't do it by myself. So I wanted to be very open and honest with the people that are in my village. But also because I'm a licensed marriage and family therapist, um, I use it also as a way to cope. So I created like a private Facebook group that was separate from my just regular Facebook page, because that's how I saw the cancer. And that's probably still how I see the cancer. That's something like separate, that's like outside of me, that's not a part of my life. So I kind of compartmentalized it a little bit. And I think the Facebook group helped me do that, because I only post in that group every time that I have treatment. So you can see every time I go, I just take a picture just to update people on how many treatments I have left, when I had surgery, how I was feeling. And so it allowed me to just separate the cancer from my everyday life a little bit. And it was also helpful because I am loved so much and I'm very thankful for my village. People will call me and text me and want updates. And I'm like, I'm not sending out like 100 emails, 100 text messages, 100 phone calls about the same stuff. So if I just create this Facebook group, it is more organized and I don't have to like respond to 15 million messages at once. The chemotherapy was like really, really difficult. I am used to losing my hair because I cut my hair off and like almost like every 4 or 5 years, I'm just like, I'm tired of my hair and I just cut. So losing my hair wasn't the hard part for me. So it really got me when I lost my eyebrows. Like it really got me when I lost my eyebrows. I'm like, where, like, what am I supposed to do? Like they're just gone. And so that was one of the things that just that really got me. The fatigue was really hard to deal with, because again, in true Deanna fashion, I was working 3 jobs while still going through treatment. So I would schedule my treatments on like Wednesday, and I had like at least 2 days of still energy left, and then I would just be in the bed all weekend, like just in the bed. I could hardly get up. Sometimes I was nauseous. I just slept a lot or just like laid there. And I've watched a lot of Netflix over the course of treatment, because I realized that's like the only thing that will like force me to also rest too. I'm really, really thankful for my village, because there was family or friends that would come up for every one of my chemotherapy sessions, and they stayed with me for a week to cook food, to take the dog out, to just to check on me, to see how it was. Like I didn't really have to do anything. So I'm very thankful for them coming. So then after the chemotherapy was over, I was really excited. On to the next stage of surgery. So I decided to have a lumpectomy. I was going back and forth about having a lumpectomy or doing a double mastectomy or potentially like getting implants afterwards. But I'm like, I don't really want to have a lot of surgeries, because I know if I had the mastectomy, I probably wouldn't have to do the radiation afterwards. But I'm like, I really just don't want to do a lot of surgeries. So I decided to have a lumpectomy. Then I had radiation probably like maybe 2 or 3 months after the surgery. I had radiation for every day for almost like a month, but there was still some cancer left after the surgery. So after the radiation was over, I had to start chemo all over again, but it was different this time. It was only 1 drug instead of the 4 that I was taking earlier. And so I think I had 13 or 14 treatments of it. And so luckily and thankfully, I will be finished all of my treatment next Tuesday. So on the 22nd is my last chemotherapy session. So I can ring the bell, I can be all excited, because then I really fully know that this journey is over at this point. But I think one of the things that really helped get me through is that I allowed myself to feel all of my feelings. So when I was tired, I would just lay down. And I think that was one of the great things about if I was going to get cancer, this was a really good time to get it because I could still work from home. So whenever I just got tired, I would just go lay down. Then I would just get back up and get back on my computer and do some work, teach a class or something, see a client. But I enjoyed having the opportunity to just lay down and rest. When I needed to cry, I cried. When I got really angry, I allowed myself to get all the anger because I got diagnosed at a point where I was like, I'm at this point in my career where I'm really had the opportunities to do all the things that I've been working really hard to do. And now the cancer just came. So now I don't really have the opportunities to be my best, great, excellent self, because now I have to like deal with all the cancer and the treatment that comes with all of that stuff. So it was really hard reconciling not being able to be my very absolute productive self because I prioritized resting. I prioritized healing. Even though I was angry that I had to, I still did it because I know it was in my best interest. I'm very thankful for my village, because I would not have made it through if it was not for the constant phone calls, mailing of all the blankets that I have, care packages that people send me, wigs that people sent me, like headbands. Like I would not have made it if it was not for the village that I have. And so now usually when I cry about the cancer, it's because I know that I've been loved so much throughout this whole thing. And so knowing that I had so much support is one of the things that like I just cry about just all the time, because I am so thankful for the people that are in my life. And so that's just like the brief version of the story. It'll be over, all said and done, next week. Like I'm so excited about it. But just like a small caveat, and then I'll be done. So originally, I was supposed to be done on February the 1st, but they added like an extra chemotherapy session onto my treatment. And so I go every 3 weeks for treatment, and just them adding like that extra session, my logical mind said, Deanna, if you need this to stay alive, it's really only 30 minutes of your life, because that's how long the infusion is. It's only an extra 3 weeks because that's the period in between sessions. But my emotional self is like, oh my gracious, like they're just adding so much more, like it's never going to end. So I had to allow myself to, feel all of my feelings, but also focus on the facts that, again, it's really only one more session. It's only another 30 minutes. But for me, it felt like I ran this marathon, ran my 26 miles at a pace that was really good, where I could stretch it out, I can make it, I can still be productive, I would still be proud of my time. And I only had that 0.2 left. And they added an extra 0.2. And it's like, even though it's only like an extra 0.2, but I just ran the 26. So I'm still, as you can tell, I'm still trying to just reconcile having this extra chemotherapy session, because it's really like I've been struggling with it. But again, it is all over next week. And like my only concern right now is, how do I celebrate? So that's one of the things that I keep trying to figure out, because I know that it has to be a really big celebration. So thank you so much for allowing me to share my story. And check yourself, know your boobs, have your partner know your boobs, have somebody know your boobs, just in case something is off. Thank you.
Wow, what a testimony. And in true Harbor Area Links fashion, we'd like to thank you, Dr. Harris McCoy, for sharing your inspiring story of faith, strength, and positivity. At this time, I'd like to introduce Dr. Yvette Drake. Dr. Yvette Drake is a board-certified partner physician currently in practice with the Southern California Permanente Medical Group, where she specializes in pediatric and adult psychiatry. She also serves as a clinical instructor at the Kaiser Permanente Bernard J. Tyson School of Medicine. Dr. Drake previously served as assistant clinical professor of psychiatry in the Department of Supportive Care at the City of Hope National Medical Center, where she utilized her medical and psychiatric expertise to help manage emotional and psychiatric distress in children and adults with cancer. She also served as attending assistant professor and director of pediatric psychiatry inpatient and outpatient services at MD Anderson Cancer Center in Houston, Texas. Dr. Drake strongly believes that utilizing a holistic approach that incorporates mental, physical, social, and spiritual health is important in maximizing overall wellness for her patients, family, friends, and community. She is passionate about mental health education and is dedicated to helping remove negative stigma of mental illness through advocacy and education. She has received many awards and honors, including the prestigious Laughlin Fellowship from the American College of Psychiatrists and the American Psychiatric Association Award Fellowship in Public and Community Psychiatry. Let's please welcome Dr. Yvette Drake.
Good evening, and thank you all so much. Thank you so much for the introduction and for the invitation to join in this awesome panel. As mentioned as part of my introduction, I've spent several years of my career working in a very specific and unique niche of medicine called psycho-oncology, which focuses on psychiatric manifestations of various forms of cancer. So this is an area of specific interest for me, and I was very glad to be able to participate in this panel today. So this first slide is a diagram that highlights that there are multiple dimensions to what we consider as health, beyond just the traditional understanding of physical health. There are psychosocial, mental, emotional, spiritual components of health, and they all overlap. Physical health is just one aspect of overall health. And for many people experiencing a cancer diagnosis and treatment, formally addressing mental health issues during this cancer diagnosis, or at the same time as the cancer diagnosis, is often the furthest consideration because there are so many other health needs that need to be prioritized. What many don't realize is that not addressing mental health concerns such as depression, anxiety, trauma-related symptoms, cognitive changes can have negative impacts on treatment outcomes and even survival rates. So in this next 10 minutes, I'm going to be highlighting some common psychiatric and psychological effects of breast cancer specifically. And I'm going to focus on diagnosis and treatment, as well as recommendations for coping strategies and cancer-specific mental health resources. Okay, next slide, please. So why is talking about mental health in the context of cancer important? Well, first of all, having a mental health condition while living with cancer can worsen outcomes. In one study, and I think this is really, really important, one study, mortality rates were 25% higher in people with cancer who had depressive symptoms and 39% higher in people diagnosed with major depression. Patients with mental health conditions might be less likely to follow treatment plans, less likely to take prevention screens, and less likely to miss treatment appointments, or more likely to miss treatment appointments. Another aspect that's important is mental health treatment in cancer patients can improve survival rates. One study found that those who received mental health treatment had not only fewer symptoms of depression, but also had longer average survival times than those who had more symptoms. Also, people who received mental health treatment during cancer treatment often see improvement in their overall medical condition, are more likely to follow through with medical care and have an overall better quality of life. The next slide, please. And so how many people with cancer have a mental health condition? It's estimated that up to 1/3 of people treated for cancer in hospitals have a common mental health condition, and rates of major depressive disorder in cancer patients are thought to be up to 3 times higher than in the general population. Anywhere from 8 to 24% of people with cancer are also living with depression. And we can go on to the next slide. So now I'm going to talk about what can happen psychologically and emotionally when we receive a breast cancer diagnosis and undergo treatment. There's also a separate set of significant psychological impacts of survivorship and long-term survivor impacts. But today, since our time is short, I'm just going to focus on diagnosis and treatment. And so on this slide, we're talking about what are the psychological impacts of diagnosis, many of which Dr. Harris McCoy has already shared in her experience. A diagnosis of breast cancer can induce psychological and emotional challenges that can include depression, anxiety, uncertainty about the future, feelings of hopelessness, desperation, shock, denial. There can also be contemplation, positive reflection, fear of recurrence, fear of separation from relatives, fear of losing sexual dysfunction, fear of losing sexual function, fear of losing interest of their partner, fear of death in worst case scenarios. Next slide, please. And so then this slide is going over the psychological and psychiatric impacts of breast cancer treatment. With different aspects of treatment comes another set of psychological and emotional challenges, including body image concerns, as we lose breast tissue after mastectomy or lumpectomy, because for many of us, the breast is a highly important part of the body that can, for many of us, not everyone, but for many, can symbolize femininity and sexuality, and surgical removal can pose an understandable threat to a woman's positive body image. And there also can be feelings of grief and loss. With chemotherapy, in addition to hair loss, patients who receive chemotherapy often report changes in their cognitive function, sometimes referred to as what we call chemo brain, quote unquote, which includes symptoms such as memory impairment, lack of concentration. Often, a lot of my patients that experience this looked very similar to my ADHD patients. And so there are other treatment agents that can cause neurotoxic effects, such as change in consciousness or delirium in more severe and acute settings. Corticosteroids are commonly used in cancer treatment and can cause a great variety of cognitive disorders and mood changes. Radiotherapy as well, or radiation, can be responsible for short-term memory loss. And so there are many side effects from treatment that can impair daily life functions and can have a huge impact on quality of life. And so next slide, please. So what are some common psychiatric symptoms and diagnoses that are more commonly seen in patients with cancer? The most common, of course, anxiety and depression. I'm going to go a little bit more into those in the next slide, but staying with this slide for a second, PTSD and trauma-related disorders can be a long-term outcome present in survivors long beyond treatment and remission. Cognitive concerns, chronic fatigue, sexual dysfunction, sleep disorders. Next slide, please. So more specifically focusing on anxiety. Anxiety is a very common emotion that we all have experienced at some point. It's a feeling of being nervous, on edge, worried, or overwhelmed. Most people will feel nervous when facing cancer because anxiety is a normal response to anything our bodies or minds see as a threat. It's when this anxiety persists for a long time, or when it starts to impact our ability to function or do what we need to do to take care of ourselves, that anxiety can be problematic. And so formally addressing it and learning ways to reduce it will be important. It's also important to recognize that there may be some physical or physiologic causes for anxiety that may be related to cancer or cancer treatment, such as hypoxia, or also known as low oxygen levels. This can cause anxiety symptoms or anxiety-like symptoms. Steroids can cause a jittery feeling that may feel like anxiety. Also, medications used for treatment of nausea, which is a known side effect of chemotherapy, can cause symptoms or a sensation that feels a lot like anxiety and looks like anxiety, but it's actually a phenomenon called akathisia. That's a pretty known effect from anti-nausea medication. So being able to identify the cause of anxiety can be helpful in treating the symptoms. Next slide, please. Depression is a very common response to breast cancer treatment and diagnosis and treatment. It often begins with feeling sad and losing interest in doing things that you used to enjoy. Again, it's a very common reaction to cancer during and after treatment. Normal sadness comes and goes. If it's persisting and affecting ability to function and participate in treatment, then that's what we're calling clinical depression. And like anxiety, depression can range from mild to severe. It's really important to let your doctor know if you have a history of clinical depression at the onset of the cancer diagnosis, because as we stated earlier, depression in patients with cancer has been confirmed to have extended the duration of hospitalization and can reduce quality of life. And so the next slide. So on this slide, I'm talking about ways to treat mental health symptoms and conditions in the cancer setting. And so at this point, many cancer hospitals and cancer departments have a dedicated department that entails psychologists, psychotherapists, psychiatrists like myself, chaplains. And so there's usually a multidisciplinary approach to addressing mental health issues in cancer patients. And I think that it's a couple of things I want to highlight briefly is just kind of like what's available for you if you're experiencing these symptoms. And so psychotherapists can provide counseling, therapy. I think it's important to highlight that in breast cancer patients specifically, couples therapy can be helpful in people who are having difficulty with fertility concerns or body image issues and concerns about how their partner is perceiving them. And also there are therapy services available for children of breast cancer patients, helping the children adjust to mommy being away for a while and the changes that that they're seeing mommy go through. And so child life specialists, I didn't put that on here, but child life specialists are often available to help children of cancer patients adjust to what's happening. And then psychiatrists, such as myself, we can provide, in addition to therapy services, medication services, usually in the form of antidepressants, anti-anxiety medications. We also can help to address symptoms of fatigue. And we also provide, sometimes in severe cases, capacity assessments. If someone is so depressed that the team is worried that they're not engaging in treatment, they're refusing potentially life-saving treatments because of the depression, we may step in to try to intervene and help everyone understand like if there are ways to improve that situation. Another aspect that I think could be helpful that some may not be aware of is psychologists are often on the team as, in addition to providing therapy, they can provide psychological testing, which can be helpful in the cases I mentioned before, that cognitive decline can sometimes be seen as a long-term side effect. And sometimes it can be helpful for patients who have experienced this and they're returning to work or grad school. A formal testing to assess for any cognitive changes can be helpful to advocate for special accommodations in the work or school setting. And so, and then other treatment options, joining support groups can be helpful, keeping journals, making time for exercise if appropriate. I know that's not always ideal or appropriate in every situation, but it can be helpful in managing mental health, and support for caregivers is also available. And I believe we have a caregiver joining us next. And so finally, I know I'm running out of time. This is actually evidence-based treatment interventions. I'm not going to go into that because I know I'm out of time. And then I wanted to share, I hate that I missed putting a slide up, but I want to share cancer-specific mental health resources. There are just 3 that I'm going to share, and I'll provide links to them later, but cancercare.org provides free professional support services and information to help anyone affected by cancer in the form of counseling, support groups, educational workshops. Cancersupportcommunity.org is another organization that's dedicated to providing emotional support for individuals affected by cancer, including families and friends. Sisters Network is another great resource, as well as Therapy for Black Girls is a wonderful comprehensive resource specifically for mental health treatment in the form of therapy and other mental health providers. So I'll end there.
Thank you, Dr. Drake, for stressing the importance of mental health in the context of cancer. Our very last speaker for this evening is Cameron Noel Burwell. Cameron is a retired executive from a Fortune 500 company. She is currently a stay-at-home mom of 2 young children. She is engaged in community service activities, which gives her an opportunity to give back. Cameron was a caregiver to both her ailing parents. She cared for her mother as she battled breast cancer. She will outline the critical things that a caregiver must do to assist those battling cancer. Please welcome Cameron Noel Burwell.
Good evening, everyone. I am so honored to be part of this panel with these other wonderful, wonderful speakers. I was sitting here listening and taking notes. Actually, that's something that I do often. And as I get into my talk, that's something that I would suggest for all caregivers. Seeing it is the night is late, let's go ahead and get started with it. What are some of the key things that a caregiver can do to help support the person that's battling cancer? Cancer is a scary word. It's a word that causes emotion. So when you're the caregiver, especially for a loved one like a parent or a family member or a partner, and they hear the word cancer, all these emotions come. You have to shore up every little bit of strength you have to be strong for them, because they're going to need that. They're going to need you to be dry-eyed and sober-minded. They will need your ears so that they can hear, so that you can hear the things that they may miss because of that emotion that gets caught up in that diagnosis. So they're going to need your ears to listen to everything that comes out of the doctor's mouth. As the doctor is speaking, I kind of jumped ahead of myself and said, take notes. I was at a doctor's visit with my mother, and I was just sitting there taking copious notes. Everything that came out of the doctor's mouth, just about, I was writing down. And he even looked at me and said, what are you doing, taking notes? I said, yes, that's exactly what I'm doing, because I have to relay this information to my sister who lives out of state. And then also, I'm going to have to Google some of the terms you're mentioning that I just don't understand. I want to be able to be there for my mom, to provide her with everything that she needs so she can make some good decisions. Another thing, while I'm talking about taking notes, don't be shy. Ask questions. That's what you're there for. In some cases, you ask the questions the person who got the diagnosis is scared to ask. They're afraid of what the answer might be, but the question still needs to be asked. That's where your role as a caregiver really comes in. You need to be their ears. You need to be their voice. Ask those questions. Ask the doctor, okay, well, this is your number one suggestion. Is there a plan B, or is this the only option she has? Ask those questions, get in there and engage with the person, because you are getting information for your loved one so that they can make proper choices that may extend their life and extend the quality of their life. Also, you're an advocate. You stand up for them. If you see a doctor is pushing or kind of bullying, guiding your person in a direction you know this person is not comfortable with, that's when you speak up and say, oh, okay, what if we decide not to do this? Are there any other options? Similar to Dr. Harris McCoy, she just did not want to do chemo. Sometimes there are recommendations from the doctors that your patient, that you know, your loved one, your mother, your sister, they definitely have strong feelings against that type of medication. That's where you speak up and say, are there any other options? Can we try something else? Can we look into something else? That's your role as the caregiver. You're their advocate, you're their ears, their voice. You, in effect, you champion them. I loved being my mother's caregiver because it gave me an opportunity to mother her and take care of her, and wipe her tears away and be encouraging to her. That all rolls up into being a caregiver. It's important also that they have a network of people who are walking their same path. I empathize, my sister and I empathized as much as we could with what our mom might be going through, but we don't know. We weren't in those shoes. Try and help her seek out people who can have that dialogue. Like Dr. Harris McCoy, she had her village. Help your person to create that village so that they always have someone there who knows what they're going through, that can help pick them up when they're feeling a little low, or when maybe there are questions they can't think of. Oh, but you know what? Mary went through the same thing and she asked her doctor. So that's why it's the importance of having people who walk in your same path. Help them create that village. And I'm so grateful to go last behind all these wonderful speakers, because I also want to speak on something that Dr. Drake spoke of around mental health. That is so key also. When you hear cancer, either yourself or cancer for a loved one, all of these negative images just start getting into your mind. And especially if you're someone who tends to be a negative person, or the person, oh, well, what about this? Oh, it's another thing happening to me again. Those types of thoughts and attitudes do not help to heal you, do not encourage you to get in there and keep the fight. As their caregiver, you were fighting with them. Just like at a boxing match, you're the person in the ring, wiping them off and spraying them with water. That's your job as a caregiver. You're in this fight with them, letting them know they're not going through it alone, and letting them know that they can fight the fight. And yes, I know you're tired, and yes, I know it's hard, but I need you to get back in there and do it. What I did with my mom, a lot of times people can do for others what they can't do for themselves. I used God forgive me, a little bit of guilt. I said, Mom, I know you're fighting hard, but I need you to fight some more. I need you to be here. So I'll be with you, give it everything you got. And a lot of stuff I told her, and I told her I appreciate what you're doing, because I know a lot of part of it you're doing for myself and my sister. We love you for it. We appreciate you for it. But we're going to need you to keep going, because we're fighting in there with you. And we can do this. We are a people of faith. If that's the case too, find some prayer warriors that will get in there and pray with you, pray for you, call on the Lord on your behalf. It's all about building the team that's going to keep pushing you till we get to where we need to go. If it's the last cancer, if it's the last chemo treatment, if it's one more radiation session, whatever it may be, do what you can to keep spurring them to go on and take one more step. I have in my notes, you're your person's cheerleader. And that's when it's really important for you yourself as a caregiver to have a positive attitude and to be able to say, yes, it's a tough fight, but I'm fighting that fight with you. You can do it. I'm doing it with you. The Lord is doing it with you. So just let them know they're not alone and that they can do it. It's a tough fight, but it's a fight they can fight. And to that point, we are caregivers. As women, we're just nurturers anyway. That's part of who we are and what we do. As mothers, we baby and raise our children. This is another opportunity. Whether the caregiver, the person you're caring for is your mother, your child, your spouse, your partner, just let them know they're not alone and you're in that fight with them. And you can win the fight. And you got to give it your all. Now, here's my last point. And I am, like I mentioned, I don't know if I mentioned, but I am a positive person. My friends tease me, they call me Pollyanna, because I am. Yeah, it's raining. Oh, but it's going to stop raining soon. That's just my outlook. I'm half full. But as that caregiver, you pour and you pour and you pour into the person you're caring for. What happens when your bucket is dry? What do you do for yourself? How do you care for yourself? That is something that you have to include in your list of things to do. You've got to carve out a little bit time for you so that you can replenish, so that you can pour it back out to your person that needs you. The thing that I said once to one of my friends when my bucket was draining, I asked her, I said, what do you do when half full is bone dry? She called and told me, you call a friend and they fill you back up. So I think I may have had a little bit of technical difficulties, but my point was, when you are down as the caregiver, you've got to take care of yourself so that you can help others. And I appreciate the time that I was able to have with you. And I just want to recap again, you're the cheerleader, you're their voice, you are their ears, you're their advocate. You ask questions, and sometimes you wipe tears. Just be there for them. Let them know they're not alone. Thank you.
Thank you, Lynn Cameron, for stressing the importance of advocating for your loved ones. We're kind of getting there, running over a little bit, but we're almost there. At this time, I'd like to bring on Valerie, Dr. Valerie Amos, for questions.
Well, first I have to just say how amazing this night has been. Every speaker has been incredible, dynamic, thoughtful, and encouraging us to think a little differently. So I have a lot of questions that came in the Q&A, but I also have some questions that are just resonating with me as we've heard such powerful words from all of our amazing guests this evening. So I'm going to start with the question that came in the chat. The question is directed at any of the panelists. What test can you take to see if you're predisposed to breast cancer? So again, any of the panelists, but maybe we'll turn to Dr. Dixon if she doesn't mind speaking on that.
Great question. So BRCA, BRCA, is the gene that you may be asking about, especially if you have a family history. So like in my family, I have a great aunt, in my husband's family, my children will need to get tested. That BRCA gene, I recommend you can talk with your PCP or primary care provider for a referral to geneticists. Geneticists, I think that's the right word. Gosh, it's late tonight. For further testing for that BRCA gene or BRCA gene.
Excellent, excellent. And the next question is a similar question. It's regarding family history. If there's a history of breast cancer on my father's side of the family, should I be concerned?
A family history is a family history. I'm definitely going to recommend that you have that conversation with your PCP about when they were diagnosed. So going back to that family history, I was raised as a single, with a single parent, but asking that history, how old were they when they were diagnosed? All of those things are factored into that Gale model, which is something that I mentioned to help assess your risk. But absolutely, either maternal or paternal, so mother or father's side, it doesn't matter. It's a family history for you. And great question.
Wonderful response. Thank you so much, Dr. Dixon. The next question is really more for our advocate, survivor, and caregiver. And this question is, any suggestions on how to increase the number of women who actually get tested for breast cancer?
One, if I can take it really quick from my perspective, what I did for my mom, like I said, use whatever you got. I'm your daughter. This is important for me too, Mom. Let's both go together. Or take one of your girlfriends, some of your sorority sisters, or some of your coworkers that you're close to. Just let's do it all together, because it may be scary. We can do it together, and we can talk our way through it, and maybe, afterwards grab a bite to eat, or just go see a movie or something where you encourage them to go by going yourself together.
Fantastic, fantastic. Dr. Harris McCoy, what are your thoughts on that question?
So I think that we have to think about it as preventative care. And sometimes this is some of the things that I also tell some of my female clients who don't necessarily want to do things for themselves sometimes, because it's like I have 15 million things on my to-do list. But part of it, if you're not going to do it for yourself, then do it for the people that absolutely love you, because they want you here for a long time. And so you can go in and get detected early, like I did, because I think I was only somewhere between stage 1 and 2. Because I found it myself, then you can be here for the long haul. So if you don't want to do it for you, because sometimes we think self-care is selfish, but it's not. Do it for the people that love you.
And when all of that fails, I remind the patient that if you think about the long-term cost of having cancer and the pain that you go through with the treatment and with everything associated with it, that little squishing, those couple of moments are so small of a risk of experience in comparison to actual cancer. That's the last thing that I drive home after everything else.
Absolutely. I'll just add a little caveat. It's a rite of passage. Some of us are smaller. And the smaller you are, the more potential what you do have is a little sensitive. However, I would take that sensitivity over having to get surgery any day. Okay? It's sensitivity for a minute. Listen to Dr. Harris McCoy's story, what she had to experience time and time again. And when she thought she was done, one more. Listen, a mammogram is nothing. Hats off to our sister and her story. But again, a mammogram is nothing compared to what many of our sisters have to experience through treatment. Screening, early screening, early screening, early detection. So I'm going back to my Q&A hat. The next question actually is for Dr. Drake. Should there be a consideration to have psychotherapy or behavioral health treatment as the comprehensive approach to breast cancer treatment?
Absolutely. And as I was saying before, I think that the need for that and the benefit of having that as a part of a holistic treatment plan has been seen and it has been recognized. And so these days, most cancer centers and cancer departments have a dedicated psychiatry and psychology team that in some cases that round with the oncologist and will, kind of from a preventive perspective, will identify people who may be at, even if they don't have symptoms currently, they may be at higher risk of, like if there's a past history of depression, these are going to be people that are going to be more likely to experience depression during their treatment. And as we said before, that can worsen outcomes if there's untreated depression during cancer treatment. Also, a person with history of trauma, may be more likely to experience what's known as medical trauma. So, having re-experiencing and nightmares from any of the procedures, or being more sensitive and hyper vigilant, in procedures. So having a multidisciplinary team present and being able to identify the potential for these things to cause some roadblocks in the treatment plan or in the long-term care can be very helpful. And so the specific question was about psychotherapy. So yes, psychotherapy, counseling, child life services, chaplain services. Chaplains can also provide a form of counseling as well as medication management if necessary, can all be helpful along the breast cancer journey.
Thank you so much, Dr. Drake. Your contributions in Harbor Area Chapter are phenomenal, and we really appreciate what you just had to say.
Thank you.
So interestingly, a question in the chat came regarding ways to volunteer with the Links Incorporated Harbor Area Chapter. So I will definitely share that this is the first of a series of health equity discussions regarding cancer. The Links Incorporated in particular, is an organization that focuses on quality leadership, education, training, and ultimately advocacy. And we are working as part of a health equity advocacy links community throughout the country and actually throughout the world. Here in Southern California, our focus is really on providing education through advocacy. And this is the first of a series of communications. Our next communication will be on March the 15th. So we're looking forward to everyone participating in that dialogue. And the focus will be on colorectal cancer or colon cancer prevention and treatment. We know that breast cancer gets a lot of discussion. However, we're still, as Dr. I'm sorry, now I'm losing my vision. Dr. Dixon mentioned the incidence of breast cancer among women in general globally is very high, but African-American women have worse outcomes. Though we're not the highest population to have breast cancer, we have the worst outcomes. Well, guess what? Colon cancer is even worse. So we're going to focus on that, spreading awareness as well. So you'll be hearing from us. You'll be hearing from the Links Incorporated Harbor Area Chapter. You've heard many individuals on this particular webinar who are participants in conversations and dialogues to come. So we're looking forward to your participation virtually, and we're looking forward to the time when we can get together in our communities and physically engage with the impact that we know we're trying to achieve through the Links Incorporated Harbor Area Chapter. So fantastic question. So the very last question that I have is really, what type of breast cancer is most prevalent in Black women and why? So again, I'll defer to Dr. Dixon if she'd like.
I believe that it is BRCA positive and HER2 positive, I believe.
Yes.
So what, and a lot of people, HER2 is associated with some worse prognosis, and then the BRCA gene being positive.
So in general, you showed a slide, I think I want to get everyone's attention, showing the different types of cancer in classification. I think it's important that women know adenocarcinoma, being that classification, is the most prevalent type of breast cancer. But to Dr. Dixon's point, when you think about genotyping and opportunities to identify the type of cancer, that information is available to us. And again, we have the most aggressive forms of cancer that are least responsive to treatment. So this is the reality. Many women who look different than us get diagnosed with breast cancer, and they're very responsive to treatment. We get breast cancer and we have, as Dr. Harris McCoy mentioned, chemotherapy, surgery, radiation, chemo again, and still maybe not cured. And this is Dr. Harris McCoy, it's not 40, okay? So the reality is we have the most aggressive types of breast cancer. The question that was posed is why? Guess what? We don't know. We know there's a lot of different factors about how these things seem to occur to us versus them. What is most important today is that we get screened, and then if we find something, we do not live in fear.
Mhm.
We cry for a moment, and then we go and get tested.
There we go.
And pain is inevitable. All of us will experience pain in our lifetime. It is inevitable, but suffering is a choice. And Dr. Harris McCoy, she shared her testimony. She is still in treatment today and on our webinar to encourage other women who look like she, that look like us, don't have to experience what she's had. And she's talked about so many facets of what her life's journey has been just to this point. So sisters on this webinar, understand that we as members of the Harbor Area Chapter of the Links Incorporated want to ensure that your journey does not end with a breast cancer diagnosis that is consistent with your death, but is consistent with your life. And that your life can be a journey where this is just a part of the story, not the whole story. So we're incredibly thankful and appreciative of all of the voices that you heard this evening, all the questions that were shared this evening, and all the thoughts, the empowered thoughts that it took to even put this experience together. So that being said, we do have a poll to share. So for those of you who are comfortable using the Zoom interface, there's a poll that will be launched very shortly. Please complete the poll. The poll is saying pre-assessment questions, but again, this is something for you to go on ahead and complete at this time. Thank you. So we're going to close our paneling very, very shortly. For those of you who've been interested in participating in the panel, thank you so much. And if you haven't had an opportunity to do the poll, please do so now. So I think at this time, we've given everyone an opportunity to complete the poll, and we certainly appreciate the feedback. We'll be sharing with our participants as well as those of you who were able to complete the poll in just a moment. We will see the results of the poll in just a moment. Okay, so great. So I see the poll at this time. I'm going to share the questions and the responses. So the first question, women of average risk begin breast cancer screening. 23% of the participants said 45, 64% said 40, 0% said 55, and 14%, I apologize, 36 said, 14% said age 36. Well, this is a controversial question. It depends on who you've asked. So if you ask the United States Public Health Service Task Force, versus the American College of Obstetricians and Gynecologists versus the American Cancer Society, you might get a different answer. So we'll just say for the point of today's dialogue, since Dr. Dixon mentioned age 40, that we're going to go with 40. And that's what most people said. So the reality is it depends who you ask. All the consensus guidelines, however, would suggest between 40 and 45. And the reality is if you have a family history, that should happen at an earlier time. The next question, what is the currently recommended imaging test for breast cancer? The first option, mammogram, 100%. CAT scan, 0%. X-ray, 0%. Thank you, sisters. I'm glad you got it. Mammogram, absolutely. Digital mammograms are becoming the test of choice. Mammograms are used for screening. We're not talking about diagnosis. Dr. Harris McCoy talked about the fact that she had already identified a lump. So for that reason, she had most likely a digital mammogram and an ultrasound, or what we call a spot compression film. The next question, how often should you get breast cancer screening? The first response, once started annually, 73%. Once started every other year, 23%. Once started every 5 years, 5%. So again, depends on who you've asked, okay? Most of the guidelines today would suggest if you get your baseline mammogram in your 40s, that you would get an annual mammogram until age 55. And at that time, you can go to an every other year schedule. But again, it depends on who you ask. The reality is, if you get a mammogram every year, between those ages of 45 to 55, you are doing fantastic. If you get yourself a mammogram at age 40 and go for your mammogram every other year, that's one of the guidelines. That's fantastic. The reality is you need to get your mammogram. And I don't know that there's anyone, well, there may be a few on this call who don't qualify for a mammogram. But again, unfortunately, not being old enough for a screening test doesn't mean the disease will not impact you. So mammograms are part of the solution. And we're focusing on what we consider population guidance. Population guidance is big picture guidance for the community, for our community. But again, it doesn't mean that that is the absolute always scenario. But again, once started, getting that screening every year, especially in your 40s into your early 50s, is going to be a critical decision. The next question, are African American / Black women more likely to develop breast cancer? Well, interesting, it's kind of a trick question. So the answer is actually no. African American women are not more likely to develop breast cancer. They're more likely to develop deadly breast cancer. They're more likely to develop aggressive breast cancer. So the incidence of breast cancer is by far more common in white women, as Dr. Dixon showed on one of her slides. However, we get the worst of the worst. So the most aggressive forms of breast cancer, the most deadly forms of breast cancer are the types of cancers that affect us, unfortunately, disproportionately, which is why this conversation this evening was so valuable and continues to be so important. So thank you so much. So those are the questions for our dialogue today. I'm going to turn things over to my sisters, Marian and Tina, for closing comments.
Okay. Thank you, Dr. Valerie Green Amos. Okay, can you hear me? Okay. At this time, I'd like to thank all of our speakers this evening. Dr. Harris McCoy, thank you so much for sharing your incredible story. You serve as an inspiration to us all. And Harbor Area Chapter will be present on the 22nd, applauding you as you ring the bell. believe me. Dr. Dixon, thank you for providing facts about breast cancer, some of the causes that we can in fact control, and then the types of screening available. To Dr. Drake, thank you for sharing about mental health and well-being, the importance of mental health on treatment outcomes, and the emotional and psychological impact of diagnosis. Cameron Burwell, thank you so much for providing insight from a caregiver's perspective. Your comment about the ears, the voice, being an advocate, all of that is very important, very key. And then also, I wanted to point out that we often focus on the patient and not so much on the caregiver as well. Caregivers need our support as well so that they can continue being of value to the family member. And then to our own Dr. Green Amos, thank you so much for providing awareness about breast cancer, our cause, Harbor Area's cause, the value of screening, and then also the available sources. We really appreciate you and your work and efforts in our community. And then lastly, I want to thank all of our participants, all of our viewers for joining us this evening. I hope this session was informative, inspiring, empowering, and I urge you to share it with your family and friends so that collectively we can level the playing field in our communities. So before you leave, just a couple of reminders. First off, that the recording will be available on our social media within the next 48 hours. And a link will be sent to all attendees so that you can share that with your family and loved ones. Secondly, there will be a brief survey afterwards. If you can stay and complete that survey, we would appreciate it. And then finally, one last thing. As Dr. Green Amos mentioned, we will have another session on March 15th on colorectal cancer, and we hope that you can join us then. So thank you so much again, and good night.